Hi everybody and welcome to this Zoom meeting. We have a special guest this evening, Dr David Eccleston, who is qualified as a doctor in 1987 from the University of Birmingham Med School. Further training in dermatology, ENT, ear, nose and throat, and I can't say that, gynecology before entering general practice. David now runs his own private medical practice in 4 Oaks, Sutton Coldfield, the Oakley Partnership, where he specialises in areas such as vaccinations, testing, including cervical testing, Group B strep testing, sexual health tests, and well person's health services. He also looks at alcohol dependency, clinical hypnotherapy, CBD treatment, as well as other health issues, including hay fever and medical weight management. But today we're going to be looking at something different. We're going to be looking at bioidentical hormones, which is something many of us probably don't really know much about. So we're going to start off by saying hello to David and giving him a warm welcome to this group, and I hope that we can learn something from this. I'm going to ask some of the questions, and I believe you are as well, aren't you, Pauline?
Yeah. Sorry, I'm just trying to make sure the link's in right in the Facebook group, and I've just
thank you. I'll commence then. Right, okay. Yes. Hello, David. First question I'm going to ask you is, what is bioidentical HRT?
Well, put quite simply, if you develop a thyroid problem, we treat you with thyroxine. If you become diabetic, we treat you with insulin. But if you develop the menopause, which, let's face it, if you live long enough, 50% of the world's population will go through a menopause, we actually treat you with chemical substitutes for your own hormones. Some HRTs will indeed have human estrogen, but the vast majority will put in non-human substitutes for progesterone in the forms of levonorgestrel, which is found in the Mirena coil, dydrogesterone, and various other substitutes. Now, what this means is that these hormones are not recognized by the body as being the same as the hormones you used to have. In the same way that popping a sweetener in your tea makes your tea taste sweet, but it's not the same as sugar. May have fewer calories, but we now know that sweetening agents often have adverse metabolic effects. So the principle, quite simply, with bioidentical hormones is we replace the hormones you are missing with exactly the same hormone. They are bioidentical to your own body hormones, which means that when you put them back into the system, the body goes, oh, wow, where have you been? I've missed you. Rather than, I think you seem a little familiar. Yeah, let's see if we get on. But it's not the same as the original hormones that you used to have. So the principle is we're replacing like with like. We're taking an apple and putting an apple back rather than replacing with a pear or a banana.
Okay, thank you. Is it licensed and approved and safe?
Well, ultimately, your own human hormones have been tested over millions of years by nature. We know that estrogen and progesterone and testosterone are essential for normal human function. And without those hormones, you can't reproduce, you can't give rise to the next generation, and you can't function physically. Now, the thing is, because bioidentical hormone replacement therapy is titrated to the individual woman's needs, then it makes it much more specialist. The example I tend to give is if you want to look fabulous, I don't know, for your daughter's wedding or a first date with a new partner, you might go to Marks and Spencer's or Zara and say, oh, I love that dress in the window. You go to the store assistant and she says, we've got it in a size 8 or a size 18. Pick the one that suits you best. Now, if you happen to be a size 12 or 14, that's no good, because you'll either look like you're trussed up because it's too tight, or you look like a sack of potatoes. But if you then say, well, actually, I love that fabric, but I'm prepared to spend a bit more, you go down the road and get that dress made by a couturier. It's going to cost you more, but you will look $1 million. Now, the problem is that the ingredients that go into this BHRT, the progesterone, the estrogen, and the testosterone, are all licensed. And the pharmacy which they are compounded in is also regulated. But because the individual prescription is made up according to the individual woman's needs, recognizing the different measurements, if you like, boobs, bum, tum, etc., then it means that the end product is actually specific to the individual woman. So you've created a totally new compound. Now, because there are literally thousands of different variations, there's no way you can license every single different variation on a theme. But all the ingredients are licensed and approved, and the pharmacy that makes up the individual prescription is regulated in the same way as any other pharmacy. So yes, they are licensed hormones, and yes, the compounding is done in an approved pharmacy.
Okay, thank you. Where do these hormones actually come from then?
Well, I think a lot of people are concerned because certainly some of the older forms of HRT, we know, for example, Premarin, and that's been around for some 25 years now. It's an abbreviation of pregnant mare's urine, and it's actually a horse hormone. So a lot of conventional HRTs are derived from rather unsavory sources. But these hormones used in the compounded preparations are purified from soybeans and yams, and modified in a laboratory, so they become identical to the individual's hormones. And we know certainly that in Japan, where they eat a lot of soybeans, that the menopause in Japanese women is generally far more smooth, far less unsettling, and the incidence of hormone-related illness is far less in those who consume a high quantity of soybeans. So in short, they're made from plant-based sources and then modified in a laboratory, so they become exactly the same as the individual woman's hormones.
Okay, so if that's the case, then how would we actually take them? Because with normal HRT, there are different ways, aren't there, in which you know, you can apply them or take them in tablet form. So how would you with these?
Yes, what we know is that if you take any medication by mouth, be it a blood pressure pill, cholesterol agent, antibiotic, hormone, whatever, pop it into your mouth, swallow it with a glass of water, it goes into your stomach, it's absorbed through the stomach lining into the circulation. The first place it then goes is to the liver, and the liver's job is to remove toxins from the bloodstream. So what you find is that of any drug that goes into the body, a lot of it is absorbed and removed by the liver as part of its filtration role. So to give oral hormone replacement therapy, you actually have to give a bigger dose to allow for the fact that so much of it is removed by the liver. So what that means is it can interfere with the clotting factors. So we know that certain oral HRT can increase the risk of thrombosis, pulmonary embolus, stroke, and so on. But with bioidentical HRT, it's either given as a cream, which is applied to the inside of the forearms where the skin is thin and the veins are close to the surface, as you can see, very close to the surface, or it can be used as a lozenge, which you tuck inside the cheek and allow it to dissolve over 10 or 15 minutes. And the hormone then goes directly into the circulation, bypassing the liver and going straight to the hormone receptors where it's needed. And in those ladies who have particular problems, should we say downstairs, with perhaps dryness, loss of sexual function, continence issues, then we can also put together a compound which is specifically designed to address libido and vaginal dryness, in addition to any hormone that is taken either intradermally or through the mouth, which means that by using much lower doses of hormones, the side effect profile of bioidentical HRT is far, far less than it is with conventional HRT when taken orally. And we do know that topical HRT is generally accepted by world experts in gynecology and HRT to be far safer than oral HRT.
Okay, so if that's the case, how long can you actually take it for?
Well, if you're diabetic, you take insulin until you're dead. And if you have a thyroid problem, you take it until you're dead. So why on earth doctors say to a woman, well, you can have this HRT for 5 years or 10 years or whatever it might be. I've got patients in their 70s on HRT. What we do know is that the time that you start the HRT is important. If you've had no HRT or no hormones for over 10 years, so you're asking about hormone replacement therapy, say in your early mid-60s, and you've never had it before, a 10-year break from natural hormones or HRT means the benefits are less clear. So someone coming to see me, for example, at the age of 62, 65, whatever, who's not had a period since they were 50 and has had no HRT, although we can help the symptoms to a degree, the data is not there because the ethics of performing clinical trials in that age group is somewhat suspect. So we don't know it to be unsafe, but we don't have proof that it is safe. So what I normally say, if you start it within that 10-year so-called estrogen window, there's no reason why you can't take it for 10, 15, 20 years or more.
So if that's the case, then like with normal HRT, which you can get on the NHS, can you actually get this on the NHS as well?
You see, this is the problem. I was an NHS GP till 2014, and I woke up one morning, probably a bit of a midlife crisis, to be honest, and just thought, actually, you know what, I'm working based upon targets and budgets. I need to make sure that 80% of my female patients have been smeared and 90% have had their MMR, and that so many patients have had their blood pressure checked in the last 12 months. And it was chasing targets and budgets. And I felt like an accountant. So that's when I decided to walk away from the NHS and become, should we say, a more old-fashioned doctor. So I actually have time with my patients and time to look at what their real needs are. But the problem with the NHS is that it was never designed to provide everything to everyone. When it was first founded in 1948, the idea was to bring healthcare free at the point of delivery to those who could least afford it. But now, of course, we've got expensive cancer treatments, sex change treatments, MRI scans, chemotherapy, sex change treatments, and we could probably increase the funding to the NHS 4 or 5-fold, and it wouldn't make any difference. And the problem with BHRT, or compounded hormone replacement therapy, is it does require a degree of knowledge, experience, and also a little bit of sort of magic in the fact you're trying to balance an individual hormone. So sometimes we don't get it right first time, so we need to tweak it maybe 3 months later, 6 months later. The NHS doesn't have the resources to do this, the skill set to do this, or the man or woman power to do it. So ultimately, like so many things in the NHS, you get the basics, and anything more than that, well, the NHS just doesn't have the budget or the skill set to provide.
So it's almost like a bespoke for that individual person. So if that's the case, then what kind of price point are we looking at for this kind of treatment?
Well, again, it depends upon what the individual needs. So if, for example, you've got a fairly straightforward case where someone just needs their estrogen and progesterone replaced, I would also recommend that in most women's cases, we also add testosterone to the prescription, because that's an essential hormone for sexual function, muscle bulk, bone health, in the same way that a small amount of estrogen is actually present in men. I don't know whether that improves their sort of sensitivity to female emotions, but we have a little bit of female hormone, men have a little bit of male hormone. And when you lose the testosterone, you lose the drive. You start to feel invisible, you don't feel sexy anymore, and you lose muscle bulk and bone strength. So putting together a combination of all 3 hormones is important. So long answer to a short question, in terms of cost, depending upon the dose of hormone you need, which is judged based upon not only your symptom score, how well are you sleeping, how bad are your hot flushes, what's your libido like, how dry are things down below. We play around with the dose, and the dose of each hormone will depend upon what your individual needs are. So you're looking at probably anything between perhaps £1 and £2 a day, depending upon the hormones you need, the dose of those hormones, and whether it's split into 1 or 2 different creams. But ultimately, it's probably the price of a cup of coffee from Costa around the corner per day.
Okay, so if that's the case then, and obviously, it's tweak dependent on your hormone levels, at what age is it best to actually, like if you think that you're starting to go through the menopause at say 45, would you advise then doing this or having bioidentical hormones, going through, the test, making sure everything's balanced and that from that age? Or would you say wait until you're sort of that bit older? Or my other question with that then is, if you've already had like the conventional HRT, shall we say, for a number of years, and then you wanted to change to bioidentical and you're over 51, which is, they say it's the average age for final menopause. If you're over that age, then can you do that? Or is it can that create problems?
Okay. My youngest menopausal patient is 32.
Yeah.
And she went through a premature menopause, premature ovarian failure, and she ended up in real trouble. I was told by her GP, "You're too young for HRT, just get on with your life," which is awful advice, because she literally felt like the rug had been pulled from underneath her feet. So she has now been on bioidentical HRT for 7 years. She dumped her rather unpleasant boyfriend. She's changed her career. She's pursuing a career in singing, which is what she always wanted to do. She's got a new, loving and very supportive partner, and it's literally changed her life.
Yeah.
But typically, I'll also get other women who try conventional HRT, and it just hasn't suited them. They've either had unacceptable breakthrough symptoms, their hot flushes may have sorted themselves out, but they're not sleeping, they're getting headaches, they're getting breast tenderness, their sex life's gone out of the window. So bioidentical HRT, there's no lower limit to when it can be started. And apart from the estrogen window, which I mentioned earlier, there's no real upper limit. But typically, I will get most patients coming to see me when they are developing the early signs of menopause. So they might be in their mid to late 40s, or when they've been trying to put up with it and just can't face it, or when they've been to see their GP and for some reason, because their great grandmother had breast cancer, they've been told they can't have it. Now, ultimately, breast cancer and indeed other forms of cancer in HRT, it's not cut and dried. You know, if you have a personal history of HRT, for example, my wife, she's had breast cancer. She's on bioidentical HRT because she did not have an estrogen positive cancer. I'm not suggesting every woman who's had breast cancer can go on BHRT, but every woman needs to be heard, and every one of them also needs to have a proper history taken, rather than just sort of lumped up in this cohort of patients saying, these are the menopausal women and these are the rules. And rules are made to be broken. And ultimately, we have guidelines, but each guideline has flexibility built into it. So again, long answer to a short question. Every case is different, every woman's different, and every prescription is different.
So every risk is different,
yes.
dependent on the individual. Every risk is different. So who would you advise then not to have it?
I think with bioidentical HRT, we know that if you look at a woman's risk of, for example, having a heart attack, having a stroke, having an early cardiovascular related death, if you track these women compared to a matched group of men with similar body weight and similar health profile, the women lag between 5 and 8 years behind the men in terms of the age of their first heart attack, stroke, and so on. But once they go through the menopause, the women start to catch up. So we know that female hormones are actually protective against many aging-related diseases.
Yeah.
So ultimately, I'm a firm believer that pretty much every woman is suitable for bioidentical HRT unless she has a hormone-dependent cancer or a history of a hormone-dependent cancer. So unless you've actually got a proven, and these are incredibly rare, a proven relationship between hormones and adverse health, then most women, I would say 95% of women, should be considered for bioidentical HRT.
Okay, can you use it for anything else other than menopause?
Oh, absolutely. There are so many well-known sort of hormone-related problems. For example, we see a lot of girls who go through a very difficult time after they've had a child, and they have postnatal depression. And most doctors will just say, right, well, you need to see a psychiatrist or a clinical psychologist, and we'll put you on an antidepressant. And after 6 to 12 months, hopefully you'll start to feel better. But if you actually measure the hormones in a lot of these ladies who have postnatal depression, they actually have a severe deficit in progesterone levels. So they're heavy on the estrogen, low on the progesterone, and you find that by putting them on progesterone and rebalancing their hormones, progesterone is nature's Prozac, it's nature's citalopram, and you can actually lift the mood immensely. Women with premenstrual headaches, again, are often progesterone deficient. Polycystic ovarian syndrome, severe sort of premenstrual syndrome. And I get some girls coming to see me who say, look, my husband has sent me saying that unless I get this sorted out, then we're heading for the courts. And you do the blood test and you find out that the week before their period, we always check the bloods on day 21 based on a normal 28-day cycle, you often find that they've got a massive drop in their progesterone levels. Hormones are so out of whack that these women are desperate to stick a bread knife between their husband's shoulder blades, but feel really bad about even thinking that. So there are so many diseases and so many conditions which are hormone related. Polycystic ovaries, severe premenstrual acne. That's something I have a big passion for, management of acne. And putting women on progesterone supplementation running up to their period can have a drastic effect on the severity of their acne.
Okay, so sorry, Pauline, were you going to say something then?
I was just saying that's useful to know. So you know the progesterone then with acne, that can affect anybody at any age, because my daughter, stepdaughter, actually really suffers with that.
Yes.
So that's really interesting.
And acne has many causes, but people seem to think that acne is somehow some sort of skin infection, but it's not. It's actually a hypersensitivity of the sebaceous glands, which are the grease-producing glands in the skin, and it's a hypersensitivity to testosterone breakdown products. So if your hormones are out of whack, then even a relatively low testosterone level will cause hyperactivity of the sebaceous glands, which then produce more sebum, which then becomes colonized with bacteria, which lead to acne. So if you can then modify the hormonal profile and suppress the testosterone with estrogen, then you can rebalance the skin and have a significant effect on the degree of acne in the individual. So acne is highly hormone dependent, particularly in females.
Yeah.
So if you know all of this, then why do so many women have an issue when they go and see their GP, whether it be for HRT, or young women go and they've got like a problem with like their skin and everything else? Why are their hormones not looked at? Why is the first port of call quite often, you're depressed, or let's give you this cream, instead of actually pinpointing what the real issue is and helping that cause?
It's a $1 million question, really, isn't it, Sarah?
Yeah.
The thing is, I was a GP for over 20 years, so I'm certainly not going to go back and sort of slate my previous colleagues who, at the moment, politically, they're not popular because of reduced availability and Zoom calls and not being able to get through and so on. And whatever the reasoning for this, GPs are expected to know a little bit about everything. But unless you actually have specific training or specific additional qualifications, very few GPs are experts in anything. Some GPs will do some postgraduate training in dermatology or gynecology or neurology or pediatrics or whatever, but they are few and far between. The vast majority of GPs are trying to do a very difficult job knowing a little bit about everything. But in the same way, you wouldn't go to a plastic surgeon and say, can you do me a knee replacement? Or go to an ENT surgeon and say, do you fancy having a crack at a breast implant? So the thing is with GPs, that they are hamstrung by their training, but also by the fact they're expected to see 40 patients in a morning surgery. And rightly or wrongly, to be faced with a woman who's saying, look, I'm not sleeping well, I'm having a few hot sweats and my husband hates me. Well, you're not really saving a life, or as a GP, you don't think you are. But having spent so much time with menopausal women, my wife included, yes, we actually are saving lives, but in the longer term rather than the short term.
Yeah, totally. Because a lot of women obviously suffer with their anxiety, panic attacks, and, a low confidence and that. So, it creates a knock-on effect in many women's lives. So, it is imperative that obviously this is addressed now and going forward, which hopefully is, and there is change. You spoke earlier about polycystic ovaries. What about if you've got fibroids or if you've got endometriosis? Where do we stand on all of that when it comes to bioidentical?
This is a little more complex. Fibroids are basically a benign muscular tumor which is found in the lining of the uterus. And effectively it makes the uterus larger, and therefore the surface area from which to bleed becomes higher. So typically someone with fibroids, they'll have heavier, more painful periods and often develop anemia as those fibroids grow. And we see that fibroids seem to be particularly common in the African Caribbean population. I remember when I worked in Zimbabwe in the 1980s, I remember removing a fibroid uterus, which was the size of an oven-ready turkey. And this was absolutely unbelievable. But we do know that that pure black Africans, and I'm using that in a generic term rather than any politically incorrect term, tend to run very high on estrogen. Patients who run high on estrogen, they have an estrogen progesterone imbalance in favor of the estrogen. They'll tend to get bigger boobs, bigger bums, put on weight, but also develop these fibroids within the wall of the uterus. And when you actually measure the blood test, you often find they're deficient in progesterone. So by placing progesterone heavy prescriptions, you put lots of progesterone in and less estrogen, you can actually address this to a certain degree and stabilize the fibroids. You can't remove them unless you have surgery, but you can certainly prevent them growing. Now, endometriosis is a bit more challenging because endometriosis, for those who are not aware, is, to put it simply, it's where the cells that should be on the inside of the uterus and therefore released during every period, instead find themselves into the fallopian tubes. They may escape and find themselves on the ovaries. They can even adhere to the outside of the bladder or the lining of the bowel. You can even get them into the bloodstream and get endometriosis in the brain. So women will get these crippling headaches every 28 days because the hormones cause these cells in the brain to enlarge and expand like the lining of the uterus. Now, you can again reduce the severity of these symptoms by addressing the estrogen imbalance, but it's a lot more complex, and we can't say that bioidentical HRT would sort out endometriosis or cure it, but it's certainly one of the weapons in the arsenal to help manage the symptoms in some cases.
Okay, thank you. Earlier on, I mentioned a couple of the qualifications that you have, but I know that you have far more than what I said, and some of them that I couldn't actually pronounce. It is a Sunday evening and I was out till late last night. So can I just ask you what qualifications you have in this field, please?
To be honest, I have no qualifications in this field whatsoever. As a GP, I went to the University of Life, and I've been working as a GP for 25 years. Before I became a GP, I did work in obstetrics and gynecology, but I don't have any sort of formal qualifications because I would need to go through gynecology for 5, 6, 7 years to get an appropriate gynecology qualification. What I do have is the fact that 70% of my patients are female, and 50% of those patients are menopausal. And most of them have been badly let down by the NHS. So my qualifications are really, I listen. I've had appropriate expert additional training. I've worked with a lady called Marion Gluck down on Wimpole Street in London. She actually trained me about 6 years ago in BHRT. And if you Google Marion Gluck, Marion with an O, Gluck, G-U-L, UCK. She is this rather lovely but slightly crazy Austrian-Australian who really is the mother of modern bioidentical hormone replacement therapy, and she has an absolute passion for the subject, and I'm in regular communication with her, and in fact we're sort of an outpost of her clinic, so patients who contact her clinic but live in the Midlands tend to come and see me because they don't need to go down to London. So that's where I've had the training, but my additional qualifications are really just experience and recognizing there's a huge unsolved problem out there.
Okay, so you can do a lot for women. What can you actually do for men?
Well, what's interesting, we know that women are used to going to the doctor. You know, they take the kids for their jabs, they go to the doctor to have their antenatal care, to have their smears, and men generally, they're either hypochondriacs, in which case they're at the doctor every day with trivial symptoms, or they arrive when they're literally dying. So what we tend to find is a lot of the women will come and have their hormonal problems managed. And then when they start to get a little bit more normalized, without wishing to be too vulgar, they actually start, should we say, feeling a bit more frisky. And they realize that their husband is kind of not quite, should we say, the style he used to be. So a lot of women, it's true, actually send or bring their husbands and say, look, you've sorted me out. Everything's working down below, and you know, I've got my energy levels back, and I'm looking in the mirror and liking myself again. But you know, I've got him next door. You know, could you put some lead in his pencil for me? So we'll often do the hormonal test, which we can perform in men as well, and we might find that his testosterone levels have dropped, or the sex hormone binding globulin has dropped off, or the estrogen levels have started to climb. You tend to find this in men who are overweight. The body fat actually starts to act as an endocrine organ and produce hormones. So the fatter the man, the more estrogen he's actually producing from his fat, which actually suppresses the beneficial effects of testosterone. So if you've got a rather cuddly husband with not too much function downstairs, losing weight and giving testosterone will often find that he's once again, should we say, running on full beam.
So this whole blue magic pill then that you can now get at your local chemist, and you don't have to go off somewhere to get it in a dodgy way, really is just, you know, patching over any real issues that are there.
I think, you know, we all know about the blue pill, but the way that works, it just improves the blood supply to the areas where it's needed to maintain or increase the duration of an erection. But ultimately, it is bypassing the normal hormonal function. Now, if you've got a man who, for example, is a heavy smoker and a history of heart disease and doesn't exercise, it may be the reason that he can't function down below anymore is because the arteries have started to fur up in the same way that they might have started to fur up in the heart and the legs and so on. So if you've got a chap who's in his sort of 50s or 60s where he's not functioning down below, it may be an early sign of heart disease. So it's certainly worth him being checked out by the GP, maybe having a cholesterol checked, exercise tolerance test and so on. But purely by giving the blue pill, or now there's a yellow pill and a white pill as well, that bypasses the problem, but ultimately it doesn't deal with it. And I think any man with erectile dysfunction that's happening on a regular basis rather than just occasional basis does suggest a circulatory problem which should be invested medically.
Okay, thank you. Looking then back to bioidentical for women, does it create weight gain? Is there a possibility of putting on weight?
Well, again, it's a question of balance. What I normally say is that if you get the balance right, it shouldn't make you gain weight. If anything, you find after the menopause, a lot of women actually gain weight, particularly boobs, bum, and thighs. And if you correct the hormonal imbalance, you can actually stop that weight gain, stabilize it, and even reverse it. But the problem is that if you give BHRT to a woman and she feels better about herself, she's going to be more sociable. You may find that she's going out more, she's socializing more, drinking more, having more dates or whatever. So there's lots of causes of weight gain, but there's no evidence that when used properly, properly balanced BHRT should have any effect on weight gain.
Yeah, because I know a lot of women say, you know, they're frightened of having like the run-of-the-mill HRT because, you know, they might put on weight. And I'm like, well, isn't it just replacing something that was already there? Or it's, you know, it's helping to, yes, okay, if the levels aren't right. And I suppose then with bioidentical, if you can, you're making it as a bespoke for each individual person, then you're less likely to have that issue of there being an imbalance in one hormone or another. So then you could gain the weight. So it's less likely.
Yeah, and it's all about balancing everything. Like I said right at the beginning, if you've got someone who needs thyroid replacement, you do a blood test first, you start them on some medication, you check it again in a month, you might then tweak the dose until you get it right. And then you check it once a year just to maintain it. And the same with diabetes. The dose of insulin determines the level of blood sugar and the control of your symptoms. And it's the same with BHRT. And when we see that patient 3, 6 months, 9 months, 12 months later, their hormonal needs may have changed, particularly if I first saw them during perimenopause, then a year later they're in full menopause. So we may need to change the doses in their hormones just to make sure that they're optimized. So anyone seeing me will get an annual ultrasound scan and an annual full female hormonal profile. So we know that at any one time that woman's hormone dose is going to be optimized for her individual needs.
I mean, the good thing about it is, you know, you were saying about how you can implement testosterone in with, you know, the formula for the individual. And yet it's so difficult to get testosterone as a woman on the NHS because it's not seen as a female hormone, when in fact we know it is, because, you know, you have to pay privately for that individually. And then that's one size fits all because, you know, you're given a cream and you're told to put this much on a daily basis. And do we actually know whether that's the right levels for us? Whereas with this, you know, everything's checked and it's made specifically for you, so it's going to incorporate maybe testosterone where it's needed more, and you may actually need more than you thought you did. And a lot of women are afraid of testosterone because they think that, you know, they're suddenly, you know, going to look like Arnold Schwarzenegger overnight and grow like a beard. You know, I mean, a lot of women have a problem with facial hair anyway when they get older. You know, it sort of like grows from one part and disappears from another. And so there's that fear that that having testosterone, that's going to happen. I mean, is it possible?
Well, what we know about excess female hair growth, particularly on the face after the menopause, it's not actually due to testosterone, but it's due to a metabolite of testosterone known as dihydroepiandrosterone and also dihydrotestosterone. So it's not actually testosterone that causes the hair growth. Now, some women, to be fair, when they're perhaps of a more Mediterranean complexion, darker hair rather than blonde hair, if they're using the HRT on their arms, then sometimes they do notice a little thickening of the hair growth. And those patients are the ones who we often say, well, we can get the testosterone to be down below to the, should we say, the hairless areas of your intimate places. So that can address that. But we tend to find that women with excess facial hair growth after menopause, if anything, that excess facial hair growth is reduced when they go on testosterone, because they're then getting less of the byproducts of metabolizing testosterone. So it's all about replacing what's missing and therefore normalizing normal metabolic processes within the body.
Okay. Now, if I was to say come to you tomorrow and say, look, I want to look into bioidentical. And I have been using, you know, I've been having normal HRT from my GP for the past 5 years. What would be the process then of me maybe coming off one lot and going on to the bioidentical, you know, and would you have to come off the hormones that you're already using to get the balance right with the blood test? Because obviously you're already going to have that estrogen and progesterone in your body.
Okay, very good question. And again, it's going to be a slightly longer answer in that if you come to me having been on HRT for several years, then clearly things are not right. You've come to see me because you're not happy on the current prescription. Now, a lot of modern HRT does contain 17-beta estradiol, which is normal human estrogen, but very few of them contain normal human progesterone. So if we do a blood test and you've been on conventional HRT, we'll often find your estrogen levels are actually fairly well preserved because the estrogen is doing the job, particularly if it's in the form of a patch or a gel in the form of estrogel.
Yeah.
But if you are on levonorgestrel or dihydrogesterone or drospirenone or any of these other what we call progesterone analogs, then if we're measuring your progesterone levels in your bloodstream, we won't find any because you're not on progesterone, you're on a different drug. So it's like saying, well, why can't I find any cocaine in the system? Well, that's because the patient's on cannabis. It's still a drug, but if you're not using cannabis, we won't find it. So if your HRT doesn't contain human progesterone, we won't find it.
Is that the same for a Mirena coil?
Yes, because Mirena contains levonorgestrel, which is similar to progesterone on a biochemical level, but doesn't have the same benefits. We know human progesterone helps you sleep, reduces stress levels, improves the lipid profile, gives you a more favorable good cholesterol to bad cholesterol, protects against certain type of cancer, including breast cancer. But if you go onto a non-identical progestogen, like levonorgestrel and many others, then you lose all those benefits. So you still get the HRT benefits, but you don't get the health protection benefits.
Gosh, I didn't know that actually.
No, I didn't know that. I mean, I tried Mirena coil and I had so many problems with breast tenderness. Literally, they trebled in size, my boobs, but it was so uncomfortable. I just felt out of sync, and after about 8 months of perseverance, I had it removed because it just didn't suit me. And I've gone back onto the Eutrogestan oral tablet at the minute.
Yes. And Eutrogestan is actually progesterone. So that is normal human progesterone.
Yeah. Okay.
So So you are now on the correct prescription, because
Yeah.
utrogestan is progesterone, and it's pretty
Right.
much the only NHS prescribable progesterone that is available. The only downside is it's a fixed dose.
Yeah, and it bloats my tummy. Since I've been back on it, my tummy bloats up. It gets really windy, as in, you know, just bloats a bit. It feels uncomfortable. Yeah, but I went back on it in, I think it was June time. I had my the marina core removed, but I've just now started to notice I'm getting back into it. My tummy's bloating up again.
Yeah. So you may well require a little bit of tweaking of the ratios of the doses between hormones.
Take it every day, and it's just, I don't have any break in it. So as you say, it's just one dosage. It's the same dosage, isn't it, really? So, yeah.
Okay. Thanks, David. I'm going to stop recording this now when I can find it.